Going live now then.
Welcome everybody to our inaugural Rising to the Challenge webinar. My name is Michelle Mitchell and I'm the CEO of Cancer Research UK. This is a new way of interacting for us here at Cancer Research UK, as I'm sure it is for most of you. During this pandemic, we really want to stay in contact with you and keep you close to our CR UK community. Many of you have told us that while most of us are staying at home and have a little bit more time than usual, you would really appreciate some brain food from CR UK. So those are the twin aims of this webinar series, which focuses on biomedical research and allows you to engage with world leaders in science and medicine who are tackling some of the greatest scientific and clinical challenges of our time. We're aiming to host roughly one webinar a month. The next one will be on the 21st of May at 5:30. A close encounter with Sir Paul Nurse, the esteemed research leader and Nobel laureate and director of the Francis Crick Institute. You'll have heard that the Crick is making an important contribution to COVID-19 testing and research, as well as maintaining its work on cancer and other diseases. But for our first webinar today, I think it's incredibly fitting that we focus on what's happening at the front line for people affected by cancer and, of course, their loved ones. People with cancer are at the heart of everything we do at Cancer Research UK, and our goal is to improve 10-year cancer survival from 2 in 4 to 3 in 4 by 2034. And we do not intend to be set back, not even by a pandemic. But this is proving tough, and you would have heard and read in the newspapers, many charities are suffering very significant income loss from fundraising. We are too, and this is affecting our ability to fund the research that will help us achieve that goal. And we're incredibly concerned at the impact the virus will have on cancer patients for potentially years to come. Many cancer patients are facing worrying delays to their treatment, and we estimate that around 2,300 cancers are currently being missed every week because people are reluctant to visit their GPs during the lockdown. And while another 400 cancers a week could be missed due to the suspension of screening, this delay could mean that many people's cancers become inoperable. At Cancer Research UK, we're doing everything we can to support people affected by cancer and their families through continued government advocacy. Our nurses helpline has never been busier, and we're working with the NHS to make sure people receive the guidance and information they need. One of the experts who is working right at the front line of this pandemic in terms of both care and policy is Professor Peter Johnson, who I'm delighted to introduce you to now. Peter was formerly our CR UK Chief Clinician, and he is now National Cancer Clinical Director for Cancer at NHS England, as well as Director of our Southampton Centre. By training, he's an immunologist specialising in lymphoma. So you're very welcome. We're also delighted to have Anne Croudass here with us today. Anne trained as a nurse and held a variety of acute clinical and research nursing roles before joining CR UK as our lead research nurse. She now trains, manages and mentors our research nurses at 18 cancer centres across the UK, a number of whom are now working at the COVID-19 front line alongside the NHS. So I'm going to spend the next 25 minutes or so asking Peter and Anne a few questions, and then I'll open the floor for questions from you. Please type in your questions into the message box on the left of your screen, and Peter, Anne and I will do our best to answer them in the time we have. So let's get on to the interesting bit, the interview. Welcome, Peter and Anne, and thank you for joining us today. I know how busy you are. I only heard Peter this morning on the Today programme. I know exactly how busy he is. So Peter, let's start with you. Could you start by explaining to us quickly the role you took up leading the NHS Cancer Programme in October 2019. What is it you're doing exactly? And I'm guessing you didn't anticipate the situation we'd be in today. So let's hear about your role.
Thanks very much, Michelle. It's a pleasure to join you this afternoon. And some people will remember I used to be the chief clinician at Cancer Research UK until a couple of years ago, and then moved and took up this position as the National Clinical Director for Cancer at NHS England recently. When I joined, we were concentrating on delivering a lot of what had been policy work that, when I was at Cancer Research UK, had contributed to the cancer plan, and that developed into the long-term plan for the NHS as a whole. So I thought that I was joining an organisation which was very focused on the goals of faster diagnosis of cancer, making sure that we get people diagnosed and treated more rapidly, working out how we bring the cutting edge research of organisations like Cancer Research UK into mainstream treatment, things like molecular targeted therapies, which we've done such a lot of work on in things like the stratified medicine program. And finally, working on how we develop the cancer workforce, in particular in the NHS, how we get more pathologists, more radiologists, more oncologists involved in treating cancer to deal with the ever rising pressures of the fact that we have an aging population and that cancer is becoming more common. So those are what I thought I'd signed up to do. But of course, around about early March this year, that all changed. And really, since then, we've been very focused on working out how we respond to the coronavirus pandemic.
Thank you, Peter. Yes, one of the lessons in life is often the job you do is not the one you ended up being persuaded to take. So we are delighted you're in this role at this time, giving the leadership that you are. But could you give us an idea of what is and isn't happening for people affected by cancer in the first months of this crisis, please?
Yes. So of course, the first thing we had to do, as this a very little anticipated crisis hit us, was work out how, as we saw this very rapidly rising number of cases of coronavirus, we needed to adapt cancer services to respond to that, and in particular how to keep people safe. We knew that we look after a very large population of people with cancer who have suppressed immune systems, either because they've had major surgery or because they've had chemotherapy or radiotherapy. And the first concern, therefore, was to make sure that they were safe from catching the virus, and that their treatment could be adjusted in such a way as to keep them away from catching it, for example, in a hospital setting. And I've spent my entire professional life doing huge lymphoma clinics where dozens and dozens of people would come and sit in a slightly drafty waiting room waiting to see me and my team of colleagues, and we had to suddenly think, actually, this is not the way. We probably should have thought it before. This is not the way we really want to practice medicine. We need to try and separate people, and we need to reduce the risk of them passing infections to one another. So we've really changed the way in which we look after people. So there was this big adjustment to how to firstly manage the crisis. And then, of course, there were the pressures of trying to free up the capacity of the NHS to respond to the coronavirus itself. How did we reduce the number of operations that were done to free up anaesthetic and ventilator capacity, and to make sure that the NHS could cope with a potential big surge in cases? So that happened really very quickly, but even as it started happening, we were thinking to ourselves, OK, we need to make sure that we protect the ability of the system to help people with cancer, to keep making the diagnosis, to keep delivering the treatment. Of course, as soon as the country started to go into lockdown and people were advised to stay at home and not to go out, we saw a huge fall off in the number of people going to see their GP who might have the symptoms of cancer. And we've seen a progressive rise over the last few years in the so-called 2-week wait referrals, the people who have potential cancer symptoms who are referred to be seen within a 2-week window, which was set up by Mike Richards all those years ago, and which has been a great success of the NHS helping people to get diagnosed and treated faster. The numbers of that had been rising very steadily, so that I think we were seeing about 40,000 people a week in the NHS before this hit. And that went down really very sharply. It hit a low just before Easter of about 10,000, and I'm very pleased to say that it's just starting to turn the corner, and for a couple of weeks post-Easter the numbers have been coming back up again, which is great. But as we were watching that adjustment and seeing that adjustment of the system, we also started thinking, how are we going to get back? How are we going to restore the services that people were needing before? Obviously, cancer has not gone away, and we were very worried, as everybody else was, about the numbers of people not coming forward who might be developing cancer, because although it was always a very small minority of people who were referred, about 7 or 8% of the people who came through the system actually were found to have cancer. We were obviously very concerned about missing those. So we've quickly swung round, particularly as we've seen the emergency kind of come off the peak and the number of cases levelling out and the number of people in intensive care slowly reducing, to start to work out what our recovery plan looks like, and in particular the areas of diagnostics and surgery, which I think are the ones which have been hardest hit. So we lost a huge amount of endoscopy, for example, the colonoscopies and upper gastrointestinal endoscopies to diagnose esophageal, stomach and colon cancers. And also a lot of CT scanners got redeployed to look after people with chest infections and potential coronavirus infections. So we saw a sudden drop off of our diagnostic capacity, and also because of the pressures on surgical facilities and ITU and anaesthetics, a big drop in surgery. So we moved quickly to ring fence and protect surgical services to make sure that we could carry on operating on the people whose cancers were really going to get worse in a short space of time if they didn't have operations. And have established a number of structures to help us do that. So it's been a very evolving scene, as it has for everybody else, from crisis management to making sure that we could maintain at least a certain level of service, to thinking quickly about how we can start putting it back together again and catching up with the backlog.
Thank you, Peter. That's a very comprehensive answer, and we'll perhaps come back to some of the points you raised later in the Q&A session. I think I've heard you talk, Peter, you've got some concerns about misinformation for cancer patients during this period. Tell us more about that. What's your concern?
I worry not so much misinformation as misperception on the part of the public, and in particular some of the survey findings which suggest that people are very reluctant to seek help from their GP. A lot of that, I think, is driven by a completely understandable fear of catching coronavirus if they go near healthcare facilities, if they go to their GP surgery, or if they have to go for tests in hospital. And part of it is not wanting to be a burden on what sounds like a really busy NHS. And we know that the great British public are always looking for an excuse not to go and see their doctor, and this is a great one. So, but I think most of it is about a genuine concern about what might be likely to happen, and they've really taken on board the message that we need to physically distance ourselves and not go near hospitals. So it's a question of trying to turn that around and make it clear that actually if people have got symptoms, we've now gone to a lot of trouble to reorganise the way we deliver cancer treatment and cancer diagnosis, and that it is safe for them to come out and get diagnosed.
Thank you. And you've played an important part, as all of the cancer charities have, and CRUK today, in getting that message across, haven't we? So over to you, Anne, now. Good evening. You're very welcome. And could you explain your role as CRUK lead research nurse? And it might be interesting for people watching. Perhaps describe it pre-COVID and during COVID, because it might be a little bit different. Thank you.
Thank you, Michelle. Yeah, so thank you for having me here this evening. It's really delightful to be involved. So my role here at Cancer Research UK as lead research nurse is to head up the team of CRUK funded senior research nurses, and they are based out at our key research sites across the UK. And I suppose the role that I do at CRUK very much reflects the roles that they perform locally. which is really all about driving the clinical research agenda, sort of facilitating the delivery of our cancer clinical trials, and really communicating the impact of our groundbreaking research to sort of key stakeholders, people affected by cancer, other health professionals, the general public, and of course our supporters. And they're very much a key interface between Cancer Research UK and the people affected by cancer with their clinical role. Obviously, as you alluded to, over the last few weeks, things have changed, and I'm now working closely with my team to ensure that, where possible, cancer trial patients can continue to receive the vital treatments that they need to tackle their cancer in a safe and appropriate manner, obviously. But I'm also supporting many cancer research nurses to refocus their skills and expertise to support the wider COVID-19 effort within the NHS. And I think the senior research team has always been a key patient-facing role for Cancer Research UK. I think that's part of the advantage of having that clinical team, I think, but that hasn't changed. And I think having such a team embedded in the NHS, able to provide us with information on the very real impact of COVID-19 on people affected by cancer is hugely valuable at this time. So that's where we are. Thank you, Anne, really helpful. Could you just expand a little? As you say, some of your nurses, our nurses, have been redeployed to join the NHS at the front line. Some are leading on COVID-19 clinical trials, but what are their experiences at the moment and how are they coping? So, yes, they have sort of moved themselves to places of need, if you like. I think first and foremost, it's important to mention that for them, the safety of their cancer patients is obviously their first priority. Many of those patients are relying on our trials. And so some of them are still, if you like, doing their day job and keeping cancer trial services running where they can and doing everything they can to help patients access the treatments that they need where it's safe and appropriate for them to do so. Of course, they're very skilled oncology nurses, so some of them have gone back into sort of standard of care routine oncology clinics, if you like, and are giving chemotherapy treatments and are running the video and telemedicine clinics and appointments that we've already heard Peter talking about. But I think the really interesting thing is that as senior research nurses, they have this fantastic capability at delivering quality research, and many of them have sort of stepped in to take lead roles on delivering trials looking to identify treatments for COVID-19. And a couple of them with very appropriate experience are actually working on hospital task force to go in and work in like emergency medicine settings, working with people who are directly affected by COVID-19. So it's quite a mixed picture across the team, but they're all using their skills and expertise they've got as research nurses to help support the effort. And I think that, you know, the feedback I get from them at this time is that, you know, unsurprisingly, there is some anxiety regarding their own personal safety and also that of their loved ones. And of course, they're very concerned for their patients who may have had to have their cancer treatments interrupted at this time. But I think the message I'm getting is that there's a real can-do attitude, and the commitment of everyone in the NHS is absolutely outstanding. And I think everyone's sort of adopted that ethos of being part of one committed team to really get through this together. So that's the feedback I'm getting.
Oh, well, we're all delighted to hear that feedback, but we're also incredibly grateful for the leadership and the commitment of our research nurses as well. So I'm going to move on now to Peter. Peter, what do you think the issues were for cancer patients before COVID-19, and what do you think the issues will be after COVID-19? And what should the NHS, the government, and we at CR UK, as well as the broader community, be doing about this?
Thanks, Michelle. Well, I think before this hit us, we were very conscious of the fact that in the face of a progressively rising number of referrals, as I said earlier, most of whom, of course, didn't have cancer, we were struggling to keep up as a system with the numbers of people coming through for diagnosis, particularly that aspect of things. The treatment, there were places where the timescales were problematic, but mostly it was the diagnostic system that was giving us the anxiety. And we were starting to get to grips with that and starting to think about how we could make diagnosis in a different way when all this happened. And in fact, just before the coronavirus hit us, we started to see the first improvement in our 2-week wait figure and our 62-day treatment figures, and then of course it's all gone off the scale. So I think we've had those issues, and as I mentioned earlier, the cancer workforce. I think one of the things we've learned very quickly during the crisis is that we can work in different ways. I've already mentioned the remote consultation and the much more efficient ways that we can run clinics either through telephones or video consultations, which is something we've been thinking about and talking about doing forever. But never really had the impetus to make that big system change that it required. So that's been fantastic, and I think we're going to keep a lot of that, because I think the patient experience of that is much better. Much less time on public transport toing and froing to hospitals, much less time sitting around in waiting rooms, and people can get on with their lives, and then we speak to them on the phone or over video. The other thing is that the diagnostic system was creaking before, and we all recognised that we needed to increase the capacity in it. And I think as we've seen how the system can come together in the face of a major threat, it's shown us that actually with a bit more collaborative working and some more effective networking and some specific streamlined and protected diagnostic capacity, we can do much more. So we're thinking, as really part of the recovery plan, how we can get our rapid diagnosis centres geared up much more quickly and effectively, and how we can network them. The workforce is going to take us longer to sort out, obviously, because it takes a certain amount of time to train professionals. But one of the things we've found, for example, trying to work out how to match people's need for cancer operations to where we had the capacity to do them, is that this cross-organisational networking can really give you some efficiencies of scale. And I'd like to see if we can reproduce those, particularly in the diagnostic system, things like radiology networks, pathology networks, which we were starting to think about, but which I think the crisis might well help us to accelerate. The other small area to mention is the fact that we've managed to carve out some capacity in the independent sector as part of the crisis response. And again, that's been a great example of how if you put the network together and you have some specific and ring-fence capacity, you can get an awful lot done. So I think we've learned a lot of lessons.
So learned a lot of lessons and some potential silver linings in there too. Right, okay, I'm going to ask you both the same question now, one at a time. What is the best advice you would give to anyone affected by cancer directly or indirectly at this time? And I'll give you a little break there, Peter, and I'll start with Anne.
Thank you. Yeah, that's a really important question. And I know that lots of people affected by cancer are worried and concerned right now. And what I would say is, if you're receiving treatment for cancer and you have any questions, then contact your clinical team, because they're very definitely the best equipped to answer those questions, because they know you, they know about your cancer, and they know what your care plan looks like. So they should be your first port of call. I think if you're receiving cancer treatment and are unfortunate enough to start getting symptoms of coronavirus, then again, get in touch with the acute oncology service that is part of the hospital where you're being looked after. Of course, if you're seriously unwell, then do call 999, but get in touch with the hospital that's treating you. And I think it's just important to highlight again that, you know, some people will have received a letter advising them that they're particularly at risk and should follow shielding measures to protect themselves, and that group will obviously include some people affected by cancer. And if you're one of these people, then you should follow those shielding guidelines. And as we know, everyone should be following the self-distancing measures. And I make no apology for this, but I just want to reiterate something Peter just touched on, that actually just to remind people that if they have a symptom that might be caused by cancer and they're worried, they should still contact their GP, not put that off. Thank you.
Peter, is there anything you would add?
No, I mean, I think Anne summed it up very nicely. I think the point to make is that, particularly at these times, if people have problems, they should definitely go to see their GP. If they have appointments, they should definitely go to the hospital, get the scans done, whatever. There's a lot of work gone into making the environment safe. And now more than ever, if it wasn't important, we wouldn't ask people to come to appointments or to have tests and things. So I think it's really important to do that. And as Anne says, the team looking after you should be able to answer your questions. So don't be backward in coming forward. If there are things which are worrying you, do make contact with your clinical nurse specialist, with your treating team, because although everybody's under pressure, actually they're there to help, and they're very happy to do so.
Very good information and advice there. Moving on, we all know science and research is going to be our route out of the problems we face with coronavirus now, and we also know it's absolutely the heart of improving cancer survival, and one day we hope beating cancer. Peter, do you envisage that the work done on immunotherapy and cancer, some of which you lead, could yield solutions for COVID-19?
Yes, absolutely. I mean, one of the joys of doing a bit of work on Twitter is that you discover that everybody is now an epidemiologist and everybody is now an immunologist, and there's a huge variety of. But actually, in some ways, you know, the amount of interest and attention this has generated for how research is going to get us out of trouble with coronavirus has been incredibly powerful. And I think organisations like Cancer Research UK stand to be the beneficiaries of this level of interest in science and what it can do for us. Certainly in the immunology field, there's a massive amount of energy, of course, going into vaccine development. For example, I think there was a very nice paper came out this week, I think in Nature, describing the 80 different vaccines which are currently under development across the world in a variety of academic and commercial groups, together with, of course, all the tests that we're trying to do, and particularly trying to sort out how we get an antibody test to see if somebody has a measure of immunity to the coronavirus after they've been infected. And that's going to be absolutely critical, getting a good one of those to making sure that we can safely come out of our lockdown and start mingling again. So understanding the minutiae of what it is that makes this virus tick, what it is that makes it a danger, and how we deal with that has been a big stimulation. And we know that a lot of the problems and the severe illness that people get into with coronavirus infection is probably not the virus infection itself, but it's the body's immune response to it. And so some of the treatments that are starting to be explored are about very slightly tuning down the immune response. And indeed, even some of the drugs that I've been testing in lymphoma, which are specifically designed to tune down the activity of lymphocytes, the cells of the immune system, when they've gone malignant. Some of those are starting to be explored in how we manage people with severe coronavirus infection. So there's a huge outpouring of knowledge. And I think we will undoubtedly get, as is often the case in situations of a great adversity, big leaps forward in our scientific understanding.
And we, of course, as country's leading charity, are very keen to make that case continuously for how research saves lives. Very important point. A question for you both again. We've partly touched upon it, Peter, but there is good coming out of this crisis in terms of innovation in the health system. We're becoming more fleet of foot, greater collaboration. Anything more you'd want to add, or any specific examples you've seen you would like to share on this webinar?
Yes. Thanks, Michelle. I think one of the standout things for me has been to see how the cancer community, I'm not sure the word community is the right thing here, but all the people who are interested in cancer has come together, and it's always been the case that there's been a very huge shared sense of purpose amongst us, but I think we've seen that so strongly in the last month. The real alignment of the NHS, of all the charities involved in the cancer field, of patients and their families and loved ones. I think it's been extraordinary to see, and we've had a weekly call with all the cancer charities, and also calls with many of my colleagues around the country on a regular basis. And the level of coherence and wanting to solve problems together is something which I think is very special to the field in which we operate. We've also learned a lot about how you do research quickly. One of the great frustrations of doing clinical research always, and one of the things which used to upset me when I was working with Cancer Research UK as their chief clinician, was how long it took us sometimes to get our trials started and to get them through the system. And we did lots of work to try and speed it up and to reduce the amount of bureaucracy. And I think the way that the coronavirus trials have happened in incredibly short order is a great example, and we're going to take some learnings for that, for how we prosecute the clinical research that Cancer Research UK can do energetically in the future. My academic colleagues from across the UK have come up with some amazing ideas. The Cancer Research UK clinician scientist fellow in Birmingham, Andrew Beggs, who's set up a whole testing lab, Charlie Swanton and the team at the Crick, who set up another testing lab, really to come to the rescue of the NHS and make sure that we could get tests done, have been enormously instrumental in changing the dialogue. So there's a whole raft of learning, I think, and new things coming through.
And there's energy, as you say, commitment, collaboration, and I mean, I've observed as well, Peter, huge resilience, people wanting to go the extra mile to beat COVID quickly so we can get back to beating cancer. And any thoughts from you? What have you seen from your area of specialism?
So I would say that my experience is actually very similar to Peter's. There's that real sense of collaboration and really sort of cutting through the bureaucracy that is sometimes associated with clinical research. And I've shared Peter's frustrations about the time it can take to get trials set up, and that seems to not be the case now with COVID trials. So there's definitely something we can learn from that. I mean, I have a research nurse in Cardiff who sort of looked at a protocol for a COVID-19 study on Tuesday, and by Friday had recruited her first patient, in 4 days. And, previous to the pandemic, it might take 300 days to achieve that. So there's definitely something we can take away from that. And I think also, as Peter mentioned earlier, about new ways of conducting trials which have emerged during this crisis, motivated by keeping cancer patients safe, keeping them out of hospital, doing more remote appointments and things with them, getting their medicines delivered to their home, and supporting them out of the hospital. I think there's a huge amount that can be learnt from that. It's a great way for keeping trials going now in the current situation, but also I think there's a lot that we can learn about setting it up as standard in the future, where it's obviously safe and appropriate for patients to be managed more remotely. I think it's a real opportunity for us to move away from that everyone has to come to the hospital for everything. But I think, the collaboration, the cutting through bureaucracy, and everyone really just committed to making things happen has been a highlight for me of this awful situation.
Great. Well, look, everyone listening will be so pleased to hear that. I have one last question, and it's not quite desert island discs, but it's going to shift us a little bit. You're looking worried now about what I'm going to ask. How do you have fun and keep yourself well during this crisis? And I've heard you play a number of musical instruments. Is that right?
Yes, I do play several musical instruments, and actually one of my main hobbies is all involved with musical theatre. I often play in the bands for shows, or I have been known to take to the stage, none of which is very compatible with social distancing. But as with everything, there's new and innovative ways of carrying on. So I've been involved in some online choirs and bits and pieces, which is an entertainment. And of course, with extra time at home, because we're not going out in the evenings, I've got no excuse not to practice my musical instruments, although I think the neighbours might have a different view of whether that's a good use of my lockdown time or not.
Oh, well, I would very much like you to be one of my neighbours. That would be lovely. Peter, tell us about you.
Yeah, well, staying sane, actually, rather sadly, I find things like doing clinics keep me sane when you're wrestling with the policy and the politics. Actually, getting on the phone and spending a morning talking to my patients and making sure that we can sort their treatments out is incredibly grounding. The other thing I've been doing is trying to organise an early diagnosis program in lung cancer, which we got agreement for funding for just before all this happened. And of course, screening for lung cancer stopped dead in its tracks. But I've been tussling with about 6 different industrial partners to stand this program up. So that's been a nice distraction. My garden is looking incredibly tidy. It's never been so clipped in all its life, in all this weather. And I have managed to fit in some novels. Although I have to say they're slightly doomy novels. I read The Heart of Darkness, swiftly followed by The Plague, the Camus' The Plague, which were things I'd been meaning to read for a long time. And I thought, well, you're in the mood, you might as well do it now.
Well, I'm ploughing through Hilary Mantel. That's a big one, I can tell you. But look, thank you for that. And we're going to move on to questions from the floor. So please, many of you taking part in this webinar, start posting more questions. We've got, as you see, 2 wonderful people here who can answer many of them. I'll go to some of them that have been posted while you were talking, Peter and Anne. First one being, will the NHS restructure to channel COVID patients to Nightingale hospitals to free up the hospitals to deal with normal cases, including cancer?
Certainly, this is a live debate at NHS England, and I know there's discussion going on about this because, fortunately, because everyone responded so well to the physical isolation, the peak of demand for critical care hasn't been as big as we feared it might be, and the Nightingale hospitals have got capacity. So I think that may be one solution. It's quite difficult to move everything out of the big acute hospital sites, but certainly what we're working on a lot is streaming, so as to keep people who might have coronavirus away from people having cancer tests and cancer surgery. So we're starting to split services into what have now been called red and green, according to whether or not there's likely to be coronavirus, and taking a lot of precautions to make sure that we protect people. So there's a lot of thinking going on about that. I don't know whether we'll exclusively use the Nightingale hospitals for people with coronavirus, but I suspect that they'll be used to free up quite a lot of acute trust capacity.
Thank you. Another one, does hormone treatment affect the immune system?
It seems to be the one systemic anti-cancer treatment that probably doesn't, to a great degree. Things like endocrine treatments for breast cancer and endometrial cancer and prostate cancer are actually things that we've been moving more towards doing as a way of helping people to have treatment and avoid the immunosuppressive effects of chemotherapy. So one of the great things that happened is that NICE, who have sometimes not been as quick on their feet as we'd like them to have been in approving new cancer medicines, have actually put through some rapid guidance to allow the NHS system to take up and use a variety of new cancer treatments, a lot of things like immunotherapy treatments instead of chemotherapy, and also some hormone treatments. So they've approved the use of a drug called enzalutamide, which is a blocker of prostate cancer hormones, so that people don't have to have docetaxel, which is the normal chemotherapy that they have for prostate cancer. So there's quite a lot of work been done in that area based on the idea that the hormone treatment seems to be okay as far as immunity goes.
Great, thank you. One more. This one's for you, Peter. Have you seen fewer lymphoma sufferers being referred to hospital, a cancer that takes a notoriously long time to diagnose?
Yeah, so lymphomas come in essentially two brands, one where they grow quickly and make you ill very quickly, and we've continued to see the people who have got those, and I'm glad to say that our numbers of referrals in my department haven't gone down very much, and we've seen a number of people with aggressive types of lymphoma who have already started on chemotherapy even while the crisis was going on. And my hospital down in Southampton has done a fantastic job of reorganising how it delivers chemotherapy services by moving them all out to the local independent sector hospitals. So we've managed to start quite a lot of people on quite intensive treatment. We all had to swallow hard and take a deep breath, patients and doctors alike, about it, but so far, touch wood, it's gone well, and we've managed to keep delivering treatment. The people that I think I'm not seeing at the moment are the people with the so-called low-grade lymphomas, where it creeps up on you over a period of months or possibly years, and my guess is that I'm going to see a lot more of those as we start to turn the referral system back on again. But by and large, yes, the young people with Hodgkin's disease and lumps in the neck and things like that have been keeping coming, I'm glad to say.
Thank you, Peter. I'll probably take the next question, which is, how would you answer how charity supporters should prioritise charities who need immediate funding to deliver urgent ongoing social support to safeguard the vulnerable, including domestic violence, against charities such as CR UK, whose current funding shortfall has longer term impact on research that will save lives? So first thing, I think it's the job of charities to inspire people to give to them and to support their cause. Each and every one of us will give to causes that they are passionate about, and we recognise that there's significant need in the community at the moment. What I would say is cancer doesn't stop during COVID, and nor can we, because we know through the spike in our helpline, we're second only to the NHS in terms of information of provision, that cancer patients and families need us today to get the best information and support about how to manage signs and symptoms of cancer, but also how to respond during this COVID period. That we are playing an essential role in the fight against COVID and have redeployed many of our frontline nurses, clinicians, doctors, researchers, pulling together the expertise that we have to beat COVID so we can get back to beating cancer. We've heard from Peter the big impact, that a significant drop in urgent referrals, that we know will have an impact on cancer survival. And all of us share, I think, on this call an ambition and a belief that it is through research and through science that not only will be able to make up that shortfall in survival that we'll experience, but we will get the breakthroughs in prevention, treatment, diagnosis, and obviously one day cures. So we need to continue to invest in cancer research during this time, and we're finding it, difficult. We've seen a 25% drop in our income in year and have had to cut our research funding, but with the support of many of you and our very generous supporters out there in the community, we hope to continue. So they would be my reflections on that point. And then nice question here, and Anne, we'll go to you first. Having gone through a period of extreme crisis management, what are the lessons you can share with us?
So that's a really good question, actually. It's nice for a period of reflection there. I would say, I think you need to be flexible. I think I've learned how important flexibility is, that you need to be open to ideas wherever they come from. It's not always necessarily people in senior positions who have all the good ideas. Good ideas can come from anywhere, so be open to that and responsive to that. Never underestimate the resilience of people in a crisis and their absolute commitment to make things happen. I've been absolutely astounded by the response and sort of stepping up, if you like, by everyone that I've worked with. And sometimes you just have to take decisions that may not be decisions you necessarily want to take, but you need to take them at the point they need to be taken and not to prevaricate. That would be mine.
So you never lose the opportunity of a good crisis. You
No.
get some good stuff done as well. Peter, what were your reflections?
Yeah, it's been a very intense month and a half. I think thinking ahead is really important, working out not just what we do now, but what we need to do next, and getting organised to deliver it is incredibly important. And I think we've clearly made lots of mistakes, I've no doubt, but we've managed to retain and restore some services already by thinking to ourselves, okay, so what is going to happen next, and what are we going to need to put in place to recover it? I think having the right team is so important, and I'm very lucky to have a really good team at NHS England, Callie Palmer and David Fitzgerald, who are the senior people, and a whole raft of very good people who are already working on the long-term plan, who've swung into action here. Most important of all, I think, is the communication that Anne touched on. Talking really regularly to lots of different people, making sure that we've got the right channels of communication and that we can harness those ideas as they come up, because there are so many people with great ideas about how you deal with this. Sometimes there's too many people with great ideas how you deal with this, and certainly the outpouring of guidelines being written by every specialist society, Royal College and pressure group that I could think of in the first couple of weeks was at times overwhelming. But actually communicating with those, keeping the lines open, making sure that we harness the best of their ideas is incredibly important. So I think, and in the end, that's what it comes down to. It's making sure that you've got the right people and you've got the right lines of communication. And
not always perfect information. You just got to make a call sometimes, haven't you?
Absolutely.
So we have a question in. Virtual diagnostics sounds great, but how can you diagnose someone when you can't physically see someone close up? Videos won't show up everything, for example, skin cancer, moles. So, great innovation, but what's missing from that? What's the value in face-to-face still?
Yeah, there is in the end no substitute for, particularly for a tricky diagnosis, for seeing somebody, feeling their pulse, seeing how they look and examining them, for sure. And we're still going to have to do a lot of that. But there's an awful lot of things that we can do remotely. And actually skin cancer is probably one of the best examples where telemedicine and the ability to take a picture on your smartphone of the mole that you've just spotted and send it to a dermatologist, or even to a dermatologist helped by an artificial intelligence program which can interpret the images, is actually an incredibly effective way of making those kinds of diagnoses. So we're seeing more and more of that happening. Certainly dermatology telemedicine is very much a thing already, and I suspect we're going to see more of that. But yes, somebody somebody trying to show me their lumps on a video consultation is by no means entirely satisfactory, but you make do with the technology you have available.
Thank you. Anne, do you have anything to add to that?
No, just I agree with that, and I think that you know, as we know, cancer is not one disease; it's over 200, and each of those will have the, you know, there were benefits and risks with diagnosis and remote consultation. So I think it will be on a case-by-case basis, really, that those decisions should be made in an ideal world.
Now, if you can answer this question, I think you might be on the 6 o'clock news before the end of this webinar. But what is a realistic time period to have a successful vaccine in place?
Yes, the dreaded question that every time we did an announcement about some scientific breakthrough, somebody would say, how long before this is in the clinic? And the stock answer in all scientific interviews seems to be 5 years. This is not going to take 5 years for sure. I think we will probably get a vaccine through early part of 2021. I would be very surprised if we get enough data from the trials that we're going to have to do to bring anything in before the end of this year, but there's a huge amount of endeavour going into it. As I say, there are 80 different vaccines in development, and a number of them are already in some form of clinical testing, and it's being done, you can be sure, at as fast a speed as we possibly can. The difficulty is it takes some time to demonstrate that these things actually work, and if I've learned one thing in 20 years of trying to do immunology, is that most of your great ideas don't work. So it's really important that these are effectively and properly tested, and my guess is sometime in 2021.
Thank you. Another question, I won't be able to answer all of these, but we'll come back to the person who's posted several, but I'll just pick up the top one. What is the focus and timelines for the relaxation of restriction of patients who are the most to the least at risk?
Yeah, so when the letters about shielding went out to people who we thought were very vulnerable, so people having chemotherapy, people who'd had major surgery and such like, went out, the original suggestion was that they should physically isolate for 12 weeks, and that will be up in mid-June, I think, by my calculation. And as we approach that point, what we're going to need to see is what the level of coronavirus infection is like in the community to get a sense of how much we can release the lockdown. And that's an enormously complicated calculation, which I'm very glad I personally don't have to do, and that it's going to be the public health experts who are going to have to try and work out how you can safely start to release people, starting with the less vulnerable and working your way up to the people that we've had in close shielding, to see how we can start to get society started again. I think we are going to be in a period of endemic coronavirus until such time as we do have a vaccine available. So we'll go from the crisis which we've seen, but the disease is still going to be there. We're all hoping that the summer will see it being that the rate of infection will be less because people's airways are less damaged by all the things that you have going on in the winter. But until we see actually what happens, we don't know. And obviously there's a number of countries around the world starting to experiment with reducing their physical isolation and their lockdown, and we're all watching incredibly carefully to see how that's going to develop. So it's an anxious and delicate art working out how to do this properly.
Thank you. I think this question will be interesting to many people on the webinar. There are some cancers which disproportionately affect BAME communities, and as the impact of COVID-19 is higher in these communities, what information and support are we giving to these communities, and how is it being monitored and tracked?
Which of us would you like to answer that?
I think I see Anne pointing at you, Peter.
It's certainly one of the worrying features of, for example, infections in healthcare workers, that it seems to have disproportionately affected BAME people in the health workforce. But I suspect that's also the case in the cases in the community, although we don't have so much detailed data on them. And one of the things we are trying to do is to specifically make sure that we are reaching those communities. We are working with the BME organisations, patient organisations, and the ones who take particular interest in cancer in my own field, to try and make sure that the message is getting out there that they may be more vulnerable. We don't yet understand the basis of the apparent increased vulnerability, whether it's all down to socioeconomic circumstances, close proximity, larger family groups, or whether there is some underlying biological tie-in for perhaps some sort of tissue type predisposition to getting severe coronavirus infection. Huge amount of work going on this, and again, some interesting and promising biological leads. But we're working hard with the groups that normally we work with for the types of cancer which disproportionately affect BME populations, such as prostate cancer, myeloma, bone marrow cancers. Working with them to try and make sure that we're reaching those constituencies and making them aware of the difficulties.
Thank you. I've got a question that's been posted to me. How long do you think it will take for CRUK's fundraising to recover pre-COVID levels? In all honesty, it's a very uncertain situation. We're running 3 main scenarios at the moment, which of course would be affected by how quickly we get back to recovering from COVID, what happens with the economy, how our fundraising holds up in these new and changed circumstances. But I am worried and concerned it could take up to 3 to 4 years to get back to pre-COVID levels. And so we do face a challenging period, not just in response immediately to COVID, but in the forthcoming months and years ahead, to ensure that we can still fund the level of life-saving research that we do today. And of course, our supporters are very, very fortunate, many loyal supporters who give to us. We want to just continue to inspire them and you to do that. So one final question. We've heard a lot about the excellent work that's happening at the moment in spite of the very difficult circumstances and worrying circumstances that we face. What do you think, Peter and Anne, just briefly, 1-2 minutes each, what do you think will be the lasting impact of COVID-19, and what do you think are the good things that will stay and that we must hold on to help us achieve our mission and our goal of improved cancer survival when we come out of this?
So, shall I go first?
Please.
So, I suppose for me, the thing to hold on to, and I make no apology for mentioning it again, is people's ability to really collaborate to make things happen. And, you know, I'm a research nurse. I've worked in cancer research for many years, and I've, ironically enough, people who are working to sort of push the boundaries of cancer treatment and diagnosis are often quite risk averse. So if you say to them, can we perhaps do our trial like this? Can we see patients remotely? Can we make, they're like, oh no, we'll keep them in the status quo. We'll bring them in like we always have done. And I think for me, what I would really like to see is us to take this opportunity to really sort of design the trials around, yes, we've got safety and data collection is paramount, but actually make them more patient-centric, what works for the patient. And actually coming into the hospital every week for 6 months probably doesn't work for them. So I would really like to capture the sense of collaboration and really putting patients at the middle and what is working for them.
That's a really excellent point, and we must make sure we hold on to that. Peter?
Yes, I completely agree with Anne about changing the orientation of how we involve patients and how we develop our research priorities. Also, I think, as we've already said, the recognition that we need science and we need clinical research as the answer to many of the problems that are being generated is absolutely dominant. And whilst Cancer Research UK does cancer, not infectious diseases, I think it's absolutely clear from how the response to the coronavirus epidemic has developed that if we're going to make a similar response to the cancer epidemic, we're going to have to harness the same level of scientific endeavour and translational research and clinical research as we've done with coronavirus, and we can do it faster. So I think we're going to see more science, we're going to see more technology, we're going to see more networking and interaction, and this collaborative spirit that's developed. And certainly from my own perspective, the way that we harness this real solidarity of the cancer community and the buy-in of charities and patient organisations to the work that we're trying to get done in the NHS, I think is going to be something that we're really going to try and sustain. Finally, we're going to spend a lot less time on aeroplanes, clearly, and going to international meetings. We had the first virtual American Association of Cancer Research meeting this week, and it was great. So I'm hoping that we can spend more time absorbing information, sharing information, collaborating in different ways in the future, which will be equally effective for taking forward the science, less damaging to the environment, and give us more time with our patients.
And the ability to water the garden in the evening for you, Peter, to keep you
Yes.
sane. Well, look, we are fast coming to the end of our time. Any questions we didn't get to, we'll endeavour to follow up. If you have made your questions anonymous, please email your name and question to charlie.mason@cancer.org.uk. So I would want to end by thanking Peter and Anne, and thanks also to our guests for joining us and being so engaged. We had some great questions. I really appreciated our time together, and it only really remains for me, on behalf of us all, to wish Peter and Anne the very best in their ongoing endeavours through the crisis and beyond. You'll shortly receive a follow-up email from us, and this will be to thank you for your participation and also let you know about the next webinars in the series. If you're interested, Paul Nurse is on Question Time this week, where I'm sure he will educate and entertain and charm in equal measure. He will be brilliant as always. And as a heads up, we'll be launching an appeal over the forthcoming weeks and months to offer the opportunity for you to help us to get our life-saving research back on track. We would appreciate any help you can offer enormously. So I hope to speak to you all again soon, and stay safe and stay well. Thank you for joining us.
Thank you.